In this episode of the ASC Podcast with John Goehle, we discuss the impact of recent weather events, provide an update on the New York City nurses' strike and how it could impact ASCs, introduce our upcoming Director of Nursing and Administrators Bootcamps, and in our focus segment, we begin our year-long deep dive into artificial intelligence with Mat Giladi from Ambusun.
Welcome to the ASC Podcast with John Goehle, the longest-running podcast specifically focused on the freestanding ambulatory surgery industry. We would like to thank our sponsors, Surgical Information Systems, providing cutting-edge information solutions for surgery providers, RFX Solutions, your all-in-one healthcare regulatory compliance software, MedServe, which is the only digital narcotic cabinet specifically designed and priced for surgery centers, helping standardize processes, compliance, eliminate paper logs and prevent drug diversion, and Ambulatory Healthcare Strategies, the nation's leading regulatory and accreditation compliance resource for ambulatory surgery centers. For more information about our sponsors, please visit our website at ascpodcast.com.
Welcome to episode 270 of the ASC Podcast with John Goehle, recorded on February 23rd, 2026, from our studios in Spencerport, New York. I'm Sue Cronkite, your co-host and operations manager at Ambulatory Healthcare Strategies. As a reminder, the regulatory landscape for ASCs is constantly changing. The content in this episode reflects the most current information available at the time of recording. We encourage all ASCs to remain vigilant and keep up with any updates or new guidelines released by relevant regulatory authorities. Joining me today is John Goehle, owner of Ambulatory Healthcare Strategies and one of the leading experts in the ambulatory surgery field. With over 3 decades of experience, John has authored more than 10 books on the ASC industry and is a highly regarded speaker on topics related to regulation, accreditation, and financial management.
So we hope all of our listeners are staying safe and comfortable and warm as we're recording this. The East Coast Bomb Cyclone. What a name, Sue.
I know. I had never heard of that before.
I hadn't either, but a lot of our listeners and a lot of our surgery centers and ambulatory healthcare strategies have been impacted by this storm, and they're just starting to recover from it. In our next episode, actually, we're going to be talking about how to perform drills in a compliant manner. This issue has come up a number of times. That's one of those things that tends to be cited quite a bit during surveys where people really don't do a comprehensive drill. So we're going to give some suggestions in our next episode on that. But a big reminder here is that surveyors, do want to see you documenting or writing up any disaster that you have as it's not proper to call it a drill, but it can actually replace a drill. Yeah. As long as you're writing up and demonstrating as part of the documentation what you learned from it. And I think that's an important thing, Sue, here is just making sure that we learn from every situation that's not good for your organization, so you don't repeat mistakes that might occur during the event.
Better prepared for the next one.
So again, I hope everybody is staying safe, and hopefully it won't have too much of an impact on your operations. The exciting thing in the last week is we did announce our 2026 Bootcamps. So those of you that are long-term listeners and familiar. For those of you that are long-term listeners, you know that our boot camps are the industry standard for leadership training in the ambulatory surgery industry. And we have 2 boot camps coming up. Let's start off by talking about what our boot camps are. These are intensive mentored training for ASC leaders, both those that are new to the industry and those that want to sharpen their skills. It also helps you to prepare for certification in the CAST credential. It's not the only thing you need to do in order to prepare yourselves to get certified, but it certainly helps. And I think it's important to note that this is not just a one-time conference, but a structured leadership development experience. So the program is a mentored program with optional weekly, generally weekly, drop-in Zoom sessions where you can ask questions and engage with the speakers. And one of the highlights of the boot camp is our 4-day virtual conference with what I consider very engaging presentations. And this year we are changing around the way we present, where we're actually going to be using a new set for this. So it's not going to look like your traditional Zoom conference where you got one speaker on the screen. And I think, Sue, that's important to note is that these presentations are multi-speaker presentations. You have multiple people that are engaged. You usually do the moderating to get people and encourage them to continuously ask questions. And it's a very interactive presentation, very different from a webinar. That's why we try to avoid calling it a webinar in any way. And certainly when you got almost 40 hours of content, that it's much more than your 1 hour presentation that you can see from other providers. So our Director of Nursing Boot Camp is going to be April 7th through the 10th. And our Administrators Boot Camp is going to be May 26th through the 29th. And we're going to provide links to sign up, but it's available at ASC-Central.com. The program is reasonably priced with discounts for clients of ambulatory healthcare strategies. And it's important to note that all of our boot camps are included as part of our comprehensive ASC Central Premium Access program. And again, more information about that is available on ASC-Central.com. Sue, our drop-in sessions have been very interesting lately, haven't they? We've had we usually have about 4, sometimes 5 surveyors on these weekly drop-in sessions. And for those that are not aware, the drop-in sessions are a benefit of being a patron member of the ASC Podcast with John Goehle. And again, information about that is available on ASC-Central.com.
Yeah, we often have the clinical surveyors, and then we usually have 1 or 2 of the life safety surveyors even on. So any questions somebody has are great resources.
And even if we don't have questions, which sometimes happens, people like to just drop in and listen.
Yeah. Everybody talks about recent things that they've seen and, any upcoming issues, and we learn a lot. We
sometimes joke that it can be a therapy session too. If somebody's been through a survey recently or is getting prepared for a survey, they do enjoy dropping in and asking questions or just listening and getting. I think one of the things that I enjoy as a surveyor is that conversation that occurs when we don't have questions. The surveyors just talk. They'll talk about recent experiences, what we are seeing out there, and I think it provides you a really good insight as to what's going on in the minds of the surveyors. So I think it's a lot of fun. Sue, we've been talking about the nurses' strike in New York City, and I know it's very regional, but it really does have an impact on, I think, the ASC industry, and I think there could be some impact nationally. So can you give us an update on what happened with the nurses' strike?
Yep, and to give the background, the New York City nursing strike started on January 12th, and it involved almost 15,000 nurses from hospitals in the Montefiore, Mount Sinai, and New York Presbyterian Health Systems. And these were all the privately run hospitals. The city-run were not involved in that. And the unions were asking for salary increases, staffing improvements, and protection of their health benefits and other benefits. So the Montefiore and Mount Sinai strikes actually already ended right around February 11th. They came to an agreement. The New York City Nurses Association reached a tentative deal with New York Presbyterian on February 19th, and that agreement includes salary increases of approximately 12% over 3 years. And that's pretty much was across the board with all 3 hospitals. There were slight differences. More nurses to ensure adequate staffing levels, and protections against AI was specific to this. So that was, I think, the first time I've heard of it being in a contract. So I guess they really had some concerns, and protection of health benefits.
The reason that we keep talking about this is because I think there's a number of things to learn from an ASC standpoint. First of all, of course, we're always competing with hospitals for benefits. And of course, as I said, this is regional, but the unions in other cities and other areas are, of course, going to watch very closely what happens in New York City. So I think it's important to note that as we're recruiting people, to make sure that we note the differences between working in a surgery center and working in a hospital. I hope that most of our nurses don't have the same concerns about adequate staffing levels, and, except when we have shortages, but hopefully those are relatively short.
Yeah, because it did seem like, obviously the, salary increases were, that was one of the things, but a lot of it was they were just really worried about patient safety. They wanted to make sure that they felt like they were giving good patient care and that they were able to, ask for what they needed to provide good patient care. And I think you get a lot of that in an ASC.
Right. And I think that's one of our selling points, too. I'm a little concerned about the protection of health benefits because, of course, that's one of those areas that is often very difficult in an ASC is that we can't always provide the same level of benefits that a hospital will. We don't have the financial resources or the access to, some of the programs that a hospital would have. So keep in mind that you might have to, provide something else in order to offset the benefits that they get in the hospital.
And one of the things that kept coming up is that the people running the hospitals are making millions and millions of dollars. So I think also part of it is just feeling like they aren't as valued of a member of the team. Yeah. So as you said, even if you can't provide everything that they might want financially or benefits wise, I think that makes a big difference. People feeling like, you need to listen to me and you need to, give me at least some of what I need to show that, I can do my job the right way. So I think there are ways around that.
Yeah, you bring up an interesting point, too, is that all of these hospitals that were involved in the strike are nonprofits. And the fact that the salaries of the executives in the hospital, in a nonprofit hospital, are so high in comparison to the salaries of the staff there, we don't find that difference in the average ASC. So I think, again, all these things can be beneficial. I did find it, you mentioned it too, the protections against the use of AI. Now, we don't have a lot of details on that. Well, we will delve into that a little bit. And of course, today we start a year-long deep dive into AI. But I think that there are concerns that AI might impact the quality of care that's being provided to our patients. So we'll have to see how that pans out. And again, we'll delve into that a little bit deeper later. It's interesting as we're talking about this, I'm thinking about how we weren't even talking about AI a year ago. And that brings us to the next topic. We weren't spending a lot of time in the last 2 years talking about anesthesia, and now that's really one of the hot topics. So you have a news item on the CRNA scope of practice.
So it's a new law in California, effective January 1st of this year. California's new CRNA law, Assembly Bill 876, clarifies and further defines the existing independent scope of practice for CRNAs. Then basically it affirms that they can provide full anesthesia services with pre-op, inter-op, and post-op without physician supervision, but with a patient order from a physician. So here are some of the key provisions from that. They define anesthesia services, which covers the entire continuum of care, which I had just mentioned. They affirm the independence. So I don't believe it's really changing things. It's just really specifying that they can work without physician supervision as long as they have that order. And they clarify what the order should be, a patient-specific order from a physician, dentist, or podiatrist, authorizing the CRNA to select, implement, and modify anesthesia care as needed. And it clarifies that the CRNA administering medications under those orders I just mentioned does not need to hold a separate prescription for those medications. So again, it's just moving toward more independence for the CRNAs, which I know there's mixed feelings out there. It's hard to say. I mean, we need more people to provide anesthesia care. So, hopefully this is a good thing in the long run. Yeah,
and this is quite important. Again, I know this is a regional issue in California. And again, we have a lot of listeners from California. But we've seen similar legislation or legislation that opens up CRNAs to independent practice too, similar to what's happening in California. So it's important for you as leaders in the ASC industry to keep an eye on what legislation is occurring. Join your state association if you're not already a member so that you can keep up with this. And understand that this is evolving very rapidly. I think we're going to see major changes in 2026 with regard to regulations related to CRNAs. And I know that many of the even larger states are already looking at legislation that could be implemented pretty quickly. And again, remember when legislation occurs, then after that the regulations have to be written to match up with the law.
Yeah, and we have found there's a lot of instances where the doctors may not want to be responsible for supervising anesthesia because they don't feel that that's really their strength in that. So, this opens up a lot more opportunities.
Sue, I just want to talk about some recent things that we've encountered. This actually started because I got an email, discounted walkie-talkies, and silly thing, but we have them in the house for emergencies, and I was thinking about it. Says, we really can't use a walkie-talkie in a surgery center, and yet there's constant need for communication, and cell phones are great, paging systems are great, but really, wouldn't it be great to be able to communicate a little bit better back and forth between your employees, especially when an emergency occurs, or as we've seen recently with weather events that keep us running. The overall goal here is ongoing communication with the staff, improving workflows and handling crises. Standard walkie-talkies, of course, are not appropriate since you have to be very careful about HIPAA. And even if you didn't disclose PHI in a standard walkie-talkie, these systems have public access. You don't want the rest of the world to know that you have something happening. Cell phones are great tools. They definitely have helped us in the industry, but they're not ideal in this situation because you have to dial somebody's number, and you're not hands-free generally. There are a number of systems out there, but the one that I'm most familiar with is Stryker's Vocera. I think that's how you pronounce it. Now, I need to point out this is not an endorsement at all. Stryker and Vocera are not sponsors, and we're certainly not getting paid in any way for mentioning them. But and there are competitors out there, and I encourage you to start thinking about this. But there are just so many benefits. When I've been on site with people that are using this equipment, it just amazes me how much more efficient they are and how quickly they can respond to things. So this particular system, Vocera, is a clinical communication and workflow platform. It's part of Stryker. It used to be independent, and it specializes in hands-free, voice-driven communication tools designed primarily for healthcare settings to help care teams connect quickly, reduce delays, and improve patient safety and staff efficiency. Of course, what I stated there is coming from some of their marketing literature. But it involves a wearable device such as a Vocera Smart Badge, which is a small, lightweight badge worn around the neck, or it can be clipped on. Or a mini badge, which allows completely hands-free operation. And the other interesting thing about it, Sue, is you can activate it by saying, "Okay, Vocera."
Kind of like a Siri thing,
yeah,
right?
Exactly.
I was wondering, how do you do it completely hands-free without it? But that makes sense.
Well, you can imagine in an emergency, it really solves some of those problems that we have. And, of course, the other thing is, I guess the Vocera also allows you to actually call specific staff by name or their role. And it does integrate with other systems for secure texting, alarm notifications, prioritized alerts, and workflow intelligence. And it runs over your wireless network, emphasizes real-time hands-free interaction, and it could be a real benefit in ASC. And by the way, it is HIPAA compliant too. So I again, I sound like I'm endorsing this product, but I just am fascinated by it, and I really encourage you to look into it. Obviously, it's an expense, and not everybody can afford these things, but it does really help with faster staff coordination, hands-free, which is really nice in a sterile environment where you don't have to touch something. It can help with improved patient throughput, keeping things moving quickly, and, of course, dealing with emergencies as they occur. So as we continue to explore ways to strengthen and future-proof our ambulatory surgery centers, one topic that stands out as both transformative and increasingly unavoidable is artificial intelligence, as we kind of discussed a little bit earlier. Today, we're kicking off a year-long deep dive into artificial intelligence with our first installment, which is a foundational introduction. We'll cover the basics of how AI actually works, share some practical, low-risk ways you can begin incorporating it into your daily routines right now, and discuss the real implications it holds for ASC operations, efficiency, and patient care in the months and years ahead. Let's take a short break and dive in with an interview with Mat Giladi from Ambusun about artificial intelligence.
Every ASC professional knows that running a surgery center takes knowledge, skill, and a strong support network. That's why we created ASC-Central.com, a place where ASC leaders and staff can learn, connect, and grow together. ASC Central is a comprehensive hub for education and professional development in the ambulatory surgery industry. Our leadership bootcamps, on-demand conferences, and membership programs are designed to meet the needs of administrators, nursing leaders, medical directors, business office managers, and anyone committed to excellence in outpatient surgery. Our leadership bootcamps are guided, mentored programs that help develop the next generation of ASC leaders. Whether you're new to your role or looking to refine your skills, these bootcamps provide the structure and insight you need, and many of them offer AEU credits for CASC certified administrators and IPCH credits for CAIP certified professionals, supporting your ongoing professional certification. ASC Central's on-demand educational library gives you access to in-depth programs on compliance, quality improvement, infection control, credentialing, finance, and more. These full-length virtual conferences are designed to be both informative and engaging, not just check-the-box webinars. Many also include CASC and CAIP continuing education credits. For those who want ongoing learning and connection, ASC Central offers flexible membership programs. The Patron membership gives you access to Zoom discussions, key conferences, and a robust resource library. The Premium Access membership adds full access to all boot camps, private consultations, staff training, exclusive content, and ongoing support from top experts in the ASC field. If you want to be part of a community dedicated to raising the bar in ambulatory surgery, visit asc-central.com or email us at info@ascpodcast.com. ASC Central, bringing ASC professionals together to learn, grow, and thrive.
So I'm here with Matt, and our co-host Sue is with us in order to keep us on track here. Matt, welcome to the podcast. Tell us a little bit about yourself.
It's a pleasure to be here, John. My name is Matt. I am the co-founder and CEO of Ambusun, which, less important than what we do, we help outpatient care using AI to do things faster. More important than that is I spend a lot of my time working with healthcare veterans with a total of 50 years plus of experience across surgery centers, anesthesia, physician practices, but also spend a lot of my time working with some of the world's best engineers that were working in AI before ChatGPT even came out. People that worked on Google's version of ChatGPT, or people who help build self-driving cars. And so my goal here is to be able to be a bridge across the healthcare and the technology worlds and help everyone evolve.
Yeah, I mean, everybody hears about AI. Everybody knows that it's going to change our lives and especially our jobs here. And I think our goal over the next year, we're going to be doing a series on AI over the next year, is to try to introduce our audience and our listeners to what is happening in the healthcare industry related to AI and how they can use AI in order to enhance their operations and make things, provide higher quality care, which is really what it all comes down to. Matt, why don't we start by talking about why should we care about AI? What's happening in the world that's causing us to be questioning it now?
100%. And I think the first question is not even why to care about AI, but why do we even care about changing anything at all?
Good point.
Because change is hard, change is scary, and almost always has consequences. The reason is simply because the current status quo is not enough. Staffing is getting harder, costs are going up faster as reimbursements are declining, regulation is not getting easier, and all at the same time, patient volumes are increasing across the board. By definition, providers are being asked to do more with less. So regardless of whether AI is the answer, the one thing we know is that the status quo is not enough, and we need to find a way to do more with less. That brings you to the question of, how do we do more with less? And the answer has always been becoming more efficient with the resources that we already have. Software did this for us the first time around, where it allowed us to go from paper to digital and speed up our processes just a little bit, right? AI is doing that same thing again. It is allowing us to go even faster, but this time, instead of accelerating the things we've already done with software, it is opening up entirely new places where you can make things faster. And just to really emphasize, I think about this a lot like playing Mario. Healthcare is you start on one side and you jump to the other side of the Mario course and you end up on the flag and your patients are happy. AI is like the little star or the mushroom that you get along the way that helps you take the same path and go across it much faster with higher points by the end. And so a really good example of how you can go a lot faster and do more with less using AI in a way that helps your patients in a significant way could be something simple like inventory management, where you already have to figure out how much to buy, do the buying, receive it, store it, plan it, use it, document that you used it, get it billed for, and then analyze everything you've done. Some of the places where AI can be helpful is forecasting the future based on all the cases you've already done and all the cases you have scheduled. What are you probably going to need? And then based on what you probably need, can it scan all the different places you can buy it from and simplify your purchasing to help you get more bulk discounts and pass off those savings to your patients? Is it able to help you use it more effectively so that your surgeon always has the right preference card up and always has the right inventory they need when they need it? So many different things, even on the billing side, making sure you actually get reimbursed for your implants, because for the first time, you can have an AI speed up the ability to review your own contracts and read when you can get reimbursed for an implant and optimize your ability to get that money back. So that's just one very simple example of across an entire workflow that you already have to do using intelligence to do the same thing faster, just like Mario getting a star or a mushroom.
So I think there's a lot of fear out there about AI, that it's going to eliminate our jobs. It's going to dramatically change the way we do business, makes our degrees less relevant than they perhaps were before. Can you just kind of address that issue a little bit?
I can. And John, I think let's call a spade a spade. AI is going to change things.
Yeah.
Anytime that anything has fundamentally changed in the way we do work, every single change comes with both things that get added and things that get taken away. When the Japanese were introduced to guns, the samurai became a little bit less relevant.
Yeah.
And so the question becomes, how do you handle the honest truth question of what do you do with all the samurai that have done such a good job of taking care of you, right? I think a few things. I think first and foremost, there is an underlying assumption here that AI is equivalent to human beings, and that is not the case. So
Right.
First and foremost, this is not wiping out a class of people. This is allowing those same people to do more faster. So the first thing you should be asking yourself is this really changing from a samurai with a sword to someone else with a different kind of material? Or is it just allowing the same samurai to do their job infinitely better? And in this case, the AI might be able to learn a lot, but the AI is never going to be able to replace 25, 30, 40 years of on-the-job experience, right? As we all know from working with doctors, we go to the PCP 100 times, only one of them do they find something that could have changed our life. But that one time is worth everything. And we need the human to be there to make sure that we are always safe in that one time. All the other times, though, right now there are staffing shortages. We can be taking some people while we make some parts of their jobs easier, that then gives them time to do other things in the facility. So that instead of being worried about how are we going to get rid of the people we have, the bigger question is how much more can we grow now that we went from understaffed to finally adequately staffed?
Yeah, that's a very good point, I think. And one thing that's very important for our audience to understand is that we are in a situation right now where we're, we have a hard time finding the staff to be able to do the jobs where we need done in our organizations. And so it's not like we're going to be getting rid of people. It's just that hopefully you're going to be able to do more with the number of people that we currently have.
Right.
Matt, I think most people, when they hear AI right now, they think of ChatGPT or Grok or Gemini. So really, what is AI?
It's a good question. If you just use AI as a noun, AI almost starts to sound like a person, right?
Yeah.
Someone in the literal computer clouds doing things on our behalf, kind of like Terminator. I think to understand what AI is, we have to break it into three words. First is software. Then is traditional AI, artificial intelligence. And third is generative AI. First, AI is not new. AI has been around since the 1950s. And AI, artificial intelligence, just means that it is a computer software that operates so well that if you don't get told it is a computer, you wouldn't be able to know yourself. It's really just about the imitation game. Mm-hmm. So to understand that, software itself, which is the baseline, is not AI, not because it's different, but because it's just not good at imitating yet. And the reason it's not good at imitating is because software itself is fundamentally just computer programming where you tell the computer what to do, you do the planning for it, and then it executes. Very similar to RPA or drag and drop tools, kind of like where you have in your software where you say, if a patient is scheduled with Dr. X, load preference card Y. Traditional AI is taking that same computer programming and then combining it with a lot of data. This is where it starts to get artificial intelligence, where it is now starting to learn things about the past that you wouldn't expect a computer to be able to do on its own. An example of this is you have a patient who is scheduled. Based on all of the past patient cancellations you've ever had, you might want to predict what is the likelihood that this next patient is also then going to cancel. And it's able to do a level of analysis that you wouldn't expect a computer to be able to do on its own. The next layer is generative AI, where it takes that computer programming, it adds everything it's learned from the past, and it uses that to figure out what it thinks is going to happen next. This could be, for example, you have a payer contract, and based on all of the other contracts it's ever read, it can take your contract and convert it into a set of rules you need to follow, right? Another way to think about the separation of these three things is like a car, where traditional software is a wind-up car. You wind it, I direct it, and wherever it goes is where I tell it. Traditional AI is a wind-up car that can tell you, based on the direction you're going to send the car, how likely is it to crash. Generative AI is a wind-up car where after it tells you how likely it is to crash, it can then change course on its own. It can generate a steering of the wheel to move out of the way of whatever it's going to run into. And this has a lot of implications. John, would it be most helpful to talk about what AI is not and what its limitations are? Or is there something else?
I think that's a good route to go, and to dispel any misconceptions, of course, too.
Beautiful. The number one thing to really call out about AI and generative AI, whatever, it is fundamentally just computer programming plus a lot of data plus some engineers who found a clever way to put those first two things together. What that means is that very, very, very similarly to working with a diesel engine versus a steam engine, just because the technology gets better, it doesn't mean the engineer becomes less important. The limitation of AI today is primarily the engineers using it. So what that means is whether you're going to do it yourself, you're going to use it with a vendor, you're going to do something straight from Google like Google Gemini, you need to make sure that the engineers building those systems have three things. Number one, they have a clean and deep understanding of AI itself so that they know the kinds of problems it is and is not good at solving at this moment. For example, I might have the best engineer in the world, but if they don't understand engines, they've spent their whole life working on bridges, they're probably not going to make you a great car. So you want to make sure that you have people that understand the tooling that they now have available to them. Number two, engineers that understand both the problem and the goal of solving it. You might have an engineer who can build the best diesel engine, but if what you really need is a set of brakes, then it doesn't matter. And then number three is you need engineers who understand the context. Whenever a newcomer comes into an industry, and if we're being really honest, John and Sue, most of the people that are the best AI engineers in the world are not people with a ton of healthcare experience, right? They're going to look at the industry and see a lot of solutions that they think should exist that already have not been put into place for very structural reasons. Making sure that those engineers understand the current state well enough to respect the rules of the road is going to be much better than having an engineer say, my car is going to go from A to B, And I don't care if there's a Dunkin' Donuts in the middle because a straight line is the fastest path. That doesn't work. You need engineers that can respect the rules of the road. So the limitation of AI is that it is just computer programming with data, and you need good engineers to make use of it. And it is very hard to find engineers that have understanding of AI itself, that have understanding of the problem they're trying to solve, and have an understanding of the context so that they don't repeat the same solutions that anyone who's been in the industry would be able to tell you in 2 seconds wouldn't work.
Yeah, I think you make a very good point there about how important it is as you're choosing consultants, as you're choosing partners, that they might not come from the healthcare field, but they have to be willing to listen to the end user and to learn from them. I mean, you and I have been working together almost a year now, and that's, of course, a big part of what you and your team have been doing over that period of time is learning more about the industry. You didn't start off as an expert in healthcare, but because you realize that this is, something that you can really get into. You have been, I'm not going to say you're an expert because you wouldn't admit it, but you're learning very quickly. And of course, you have people like myself and some other leaders in the industry that help keep you on track. But it is so important. I think, there's a lot of money in AI right now, as we all know, and which means it's bringing in actors that might not necessarily really want to learn everything that they need to learn in order to really do a good job in the healthcare field.
Absolutely. If I can give a quick example, actually, let's take Southwest Airlines. Southwest Airlines was made by a lawyer who's never ridden a plane before. And there's probably the question of, well, then why did it work? Airlines are a super regulated industry, all these different things. The reason it worked is because he might have been a lawyer, but that meant he was able to take the time to respect the rules of aviation and learn all the laws. And as other people tried to stop him from building that airline industry, he was able to win those court cases because he understood the rules of the road literally. What's going to be really important here, I think that the people that are going to be able to do the most good with AI are the people that can bridge where the industry is today with where it needs to be tomorrow, without forgetting the fact that it is the way it is today for very good reasons. The people working in this industry are caring, hardworking people, and you need to understand their world. You need to be a lawyer who reads the existing contracts before you can say, I should make an airline that looks like X for the first time ever.
So how does AI work? Give us, it's kind of a basic question, I guess, but I'd venture to say that most of us really don't understand exactly how this concept of AI works.
Beautiful. And this is something we could do a whole episode about in deep detail, how deep we want to go. I'm going to stay at the highest level for right now.
Right.
At the highest level, what AI is doing is expert level pattern recognition. And the only difference between traditional AI and generative AI is whether you use that pattern recognition to predict the future or whether you use that pattern recognition to try and do something in the future. So first, where do you get that pattern recognition from? And then second, what do you do with it? First, the way you get that pattern recognition is by first collecting as much data as you can, first generally about the world, and then secondly, about very specific topics that are incredibly relevant to the kinds of problems you want to solve. Then you take amazing engineers and you throw them at that data and you have them create really fancy math to figure out the patterns within that data. And it essentially creates one really mega long equation that has weights and variables. And it's just figuring out a set of variables and how important each variable is. And based on that math, coming up with future predictions, right? Now, the next step, once it has all the data, and then it adds that fancy math to create an equation that is more general purpose because it's been trained on everything in the past, the next step is to test that data into the future. And we'll talk about how to be responsible with AI. But for example, let's say you have 100 data points. You might use 75 to create your pattern recognition, and then the next 25 to make sure that when you introduce new scenarios that your equation still works. Because what you don't want to do is have an equation that only works in one situation. Mm-hmm. The last step, once you have the pattern recognition, you've made sure it's relevant for new types of data. Finally, you figure out what to do with it. Traditionally, you just predict the future. How likely are you to need something? Now we're coming up with AI that is able to predict and guess what it thinks that you want. And this feels scary. Like, how do you trust a computer that's never met you before, right? But it's very similar to how a human would operate. Let's say you have a scrub tech. This scrub tech, the best scrub tech in the world, would have visibility into 100 million surgeries. We'll have seen every single type of surgery and edge case you can imagine. And so then when the surgeon holds out their hand and doesn't say anything, what is the scrub tech going to do? The scrub tech is going to guess, what does the surgeon want? And the scrub tech knows there's a 99% chance they want a hemostat and a 1% chance that they want a retractor. And then they hand over the hemostat, right? AI is the same way. Traditional software, you have to say, if I held out my hand, give me X, give me the hemostat. Traditional AI is when the doctor holds out their hand, what is the likelihood that they want the hemostat? Generative AI is able to then hand you the hemostat, tell you why it handed it over, and say, but do you want a retractor?
Yeah.
And actually do that action on your behalf. And as you noticed, John, per your question earlier, the scrub tech still needs to be there, and the surgeon still needs to be there. You just need both people to be the best that they can. Mm-hmm. AI is about allowing all of us to be the best that we can.
Mm-hmm. That's a great analogy. Sue and I were just turn the microphone off for a second to say you really nailed it in trying to help people to understand how it works there. I mean, this is a very difficult concept, and I think we're trying to break it down here, and it will take a year to talk about all the different elements. And over that next year, we're hoping to take everybody to the next level. So there's a lot of people right now that are scared about the implementation of AI or about doing it wrong or that it's going to set you in the wrong direction. I know myself, working in the regulatory field, as we change the way we search for information on the internet now, we have to make sure that we get accurate information from reliable sources. How can we be responsible with our use of AI, and how can we keep ourselves from getting into trouble?
Absolutely. And I think that we just have to all first be honest with ourselves. If we're not responsible with AI, we can get into trouble. And not just ourselves get into trouble with regulators, but patients can get hurt.
Yeah.
I mean, just to give like a very real and candid example, I mean, my mom was a physician who had an injury, and she was supposed to get a certain level of care, and she wasn't able to get it on time because of a denied prior auth. That wasn't supposed to happen. And if we mess up a prior auth for a patient because we were trying to go faster, that's a real human life that gets affected. Yeah. It's not just a number. And I think it's really important that we all remember that. These aren't rules that we have to follow just for compliance. These are rules we have to follow because we care about doing what matters most to us, which is taking care of patients. Given that, there's 3 questions we need to be able to answer. First, how do we make sure we understand what the AI is doing? Second, how do we make sure that the AI is accurate regardless of how much we understand? And then third, how do we make sure that in those critical moments, the ones that really can affect another person, that we have safeguards in place, because even 1% of hurt patients is too many. First, to make sure it's working, one of the best parts about generative AI is that for the first time ever, it can generate explanations. And so what you should be looking for is explainable AI. Vendors, partners, programs, software, whatever it is, that not only does work on your behalf and with you, but explains the reasoning and the steps behind what it did, cites its sources clearly so you can very quickly audit. Third, makes it incredibly clear how it's checking its own work. And then fourth, makes it easy for you to adjust anything you disagree with, because editing your work should not take just as long as doing it yourself to begin with. Number 1. Number 2, accuracy. Assuming it's fully transparent, you want to be able to understand for whatever system you're using, how does it know it is accurate? Number 1, we talked about all that data. Where are they getting their data? Where are they getting their expertise? You don't want to have an AI that has only been given data about fire trucks doing work on your patients, right? So what is its inputs? Number 2, evaluations. You want to make sure, what my co-founder at Ambusun, he used to work at Waymo. And one of the edge cases they have to handle at Waymo is, what do you do if a person lays down in the middle of the road for 3 minutes? You can't run over them.
Yeah.
And so you need to have a robust set of evaluations or tests to make sure the AI can properly handle the edge cases, which is where people get hurt if you mess that up.
Mm-hmm.
And then third, and this is what's really important to understand, speaking of accuracy, the biggest drawback of AI is that it's something we call stochastic, which means it is probability based, meaning that every 100 times, it'll give you the right answer 99% of it. Or it will give you the right answer 100% of the time, but in 99 different ways. And what you wanted to make sure is that there are some questions where the closest answer matters and other questions where the exact answer matters. And whoever you're working with, it should be very important that they ask them, where have they strategically chosen to use AI because it is a new problem that needs it, versus where have they decided to intelligently play it safe and use rules-based software to make sure that it is exactly what you need 100% of the time without any guesswork or any checks necessary. Once you have transparent AI that is explainable, then you have accurate AI with good inputs, good evaluations, and good distinguishment between AI versus rules-based elements. The last thing is making sure that whatever systems you're using have human-in-the-loop capabilities. They make it so that they've identified the most important parts of the process and made it easy for a human to get involved and be proactively alerted at those moments. Really good example, even without AI, a really bad billing software would allow a biller to write off a claim without even talking to the admin.
Yeah.
A really good billing software would say, hey, write-offs are pretty important. You should just flag to the admin for approval before it gets done. And all to say, across all of this, transparency, accuracy, human in the loop, this is all very similar to working with a human employee. When you hire somebody, you need to trust them. You need to understand how they do their work. You need to make sure their work is good. And you're probably not going to be happy with your hire if you end up having to redo all the work yourself. Mm-hmm. All the principles that we use to assess existing staff can be translated to assessing AI. And I think the coolest part here is staff augmentation is powerful with AI because AI can finally do the type of work that traditionally staff had to do without any help. Mm-hmm. But that means that we still have to be just as stringent with what we do with AI as we would do with our real human stuff.
You know, Matt, as I'm listening to you, I'm thinking about our quality improvement programs and how quality improvement is a process of looking at information, looking at data, and making adjustments on the fly in order to improve the quality. And that's like inherent in AI here, large learning model, the LLM, which you haven't mentioned, but you probably just want to explain that a little bit, to our audience, is that a good, robust system, as you've just been describing it, is not much different than what we do or we should be doing in our quality improvement programs.
100%, right? I think the reason we consider those values and principles is because they're supposed to stand the test of time and environments, right? The same way, like I see AI as in some ways being an incredibly effective intern. Mm-hmm. And it's just an intern that you can onboard without any of the drama. And what you have to do though is make sure that your intern has all the right precautions. And as AI gets better, it'll go from being an intern to a colleague to a full employee you can manage. But across the way, quality, constant and never-ending improvement, compliance, regulation, the whole 9 yards, it applies just as much, if not more here.
I hear a lot of people mentioning, I got the wrong information out of the system. I was coding some cases and, 50% of the time the AI was coding it wrong. But that's where LLM, large learning models come in, where it's you're looking at that incorrect information that's there, you correct it so that mistake never happens again. Again, a very important part of quality improvement, which I think translates very well into what you're describing here.
Correct. And I want to call out, John, let's actually take that. I think that's a really good example of where you need to be really careful. Let's say you're taking coding. There are multiple different ways to take an op note and turn it into a medical code. Yeah. And all of those different ways can be called AI but only one or two of them are actually really effective, high consistency ways of doing it. AI is not a term, it is an umbrella term. And part of the scrutiny we need to have is just because someone says they're a coder, it doesn't mean they're a certified coder. It doesn't mean they're a certified coder who's been in your specialty. It doesn't mean that they've had years of experience and seen cases the way you handle them. Just because something looks like it fits the bill does not mean it is actually what you need. And having scrutiny over what you're using, how it's working, where its experience comes from. You should almost see AI truly as a teammate whose resume you have to scan before you start working with them. And understanding everything we just talked about. Is it a transparent system that tells you why it chose the codes? Is it an accurate system where they can tell you the medical data that they use to try and get there, the evaluations they use to handle the edge cases, the AI versus rules-based elements to know where they can avoid errors that are not unnecessary? Human in the loop systems to make it really easy to say, hey, here are 3 codes that we could have chosen. Do you want to select this instead? As opposed to you having to rack your brain on your own. So many little pieces. AI is a blanket statement, not a specific tool. And we need to be incredibly, incredibly specific with how we are solving our problems and making sure that we don't get upset with a hammer for not being a pile driver when we just said, which tool do you want, and didn't describe the difference.
So, Matt, one of the goals of the podcast here has always been that when people are done with an episode, they can immediately take something from it and act, in their business. Many of our listeners, of course, are listening on the way to work in the morning. So, quite literally, it's something they could do, in 5 or 10 minutes after doing that. And when you and I talked about this episode and how we were going to introduce AI, one of the things I challenge you with is give them some homework this time. I don't think we've ever told our audience to have some homework, but to really take the concepts you've been talking about and start very simple in doing something that, changing something that you'd probably do every day and do it differently using, the concepts you've discussed today. So have you got something for us?
Of course. If you give me homework, I have homework to give everyone else.
That's right.
It's the homework train, hot potato. Here's what I would say. There's a piece of homework I can give for how you think about your actual facility, and a piece of homework about how you generally work in day-to-day life.
Yeah.
As it relates to your facility, one thing you can do is, as you are thinking about what tools you want to bring in, having a 9-point checklist that covers all the bases you need to cover to make sure at the very least it is HIPAA compliant. Number 2 is something you can do in your day-to-day life. For number 1, that 9-point checklist, really similar to what you're already doing with your existing software. If you're working with a vendor, do you have a BAA signed? Do they have a letter of attestation that they are HIPAA compliant and ideally SOC 2 and even ISO 27001 compliant? Are they fully insured across general, cyber, tech errors and emissions? And the 4th one is really important. Do you have clear data ownership? You should be able to know for certain that you have full ownership of your data, that anything that the other partners are doing with it is with your consent.
Yeah, that's
5th, that you have well-maintained logs of all software actions, because especially if the AI is going to have to be doing more things and explaining itself to you, you want to have a log of all the things it's done, not just what it's doing today. 6, access controls and identification management, multi-factor authentication, etc. 7, encryption at rest and in transit, basically meaning that the data is unreadable until the exact moment it's needed. 8th, data buckets and firewalls. If you're working with a partner, or even if you're building yourself and you have, let's say, 5 centers, you want there to be 5 different places where that data is stored rather than mixing it all together. And then finally, 24/7 surveillance and proactive security testing, the same way you would do with any software system. So that's a 9-piece checklist you can use on HIPAA. For yourself personally, though, and this is what I find more fun, any question that you've wished you could ask Google, but you think you can't, try asking Google Gemini or ChatGPT. Really simple example. I was at dinner the other day. I'm a really big foodie. I took a picture of the menu with my phone, uploaded it to Gemini and said, hey, I'm a foodie. My girlfriend is super picky, and we're on a double date with a group of people that are vegetarian. I want to try something really new and delicious that I can share with the table. What would you recommend? And it actually not only spit out an answer, but the waiter agreed. The server or hoster agreed. And that was really cool. It was a great dinner. And it was something I wouldn't have found on my own. So as a rule of thumb,
it's not a Google search.
It's not a Google search, right?
Right. But it was as simple as a Google search, right?
Simple as a Google search. It was just, what should I eat on this menu? The way I think about it, John, is the core value in AI is that it is changing the importance of knowing things into the importance of just asking questions.
Yeah.
And so now whenever you do have a question, anything that feels like it's too niche or unanswerable by Google, just try asking ChatGPT, Gemini, whatever chat agent you want, and see what it says. Right. And if you want to make sure that it's accurate, ask it to cite its sources, and it will.
Matt, this has been fantastic. I think it's a good introduction. I think you've just, I mean, we've been talking for a half an hour, and of course you have just like skimmed over the top of this whole concept. But I think you've done a great job, and hopefully our audience will do their homework, and in a month or so we'll come back and we'll talk a little bit more in depth about some of the concepts we've discussed today. But thank you so much for your time.
Absolutely, it's my pleasure. Thank you so much for having me.
Thank you. In this segment, we provide an update on upcoming topics for the podcast, our upcoming virtual conferences, and upcoming speaking engagements for John and his staff and other events in the ASC industry.
We did want to remind everyone that you just heard our part one of our series on artificial intelligence. We also have a ongoing deep dive into the accreditation organizations. We've already published episodes with Quad A and ACHC, and coming this week, later this week, is actually going to be a discussion with AAHC. And then we've already arranged for DNV to be on the podcast. And we're still trying to schedule something with the Joint Commission. So, again, if anybody from the Joint Commission would reach out to us, we'll be able to expedite that. But we're going through some other channels. So I think you're going to find these upcoming focus segments and these particular topics very engaging. The virtual conference for the ASC Director of Nursing Bootcamp, as we mentioned earlier, is going to be April 7th through the 10th. And for more information, visit asc-central.com. And we will provide a link in the show notes.
The American Academy of Ambulatory Care Nursing's annual conference is April 14th through the 17th at the Hilton Orlando in Lake Buena Vista, Florida.
And ASCA and SAMBA's combined conference this year and expo is going to be May 13th through the 16th, 2026 in Washington, D.C. And Ambulatory Healthcare Strategies and the ASC Podcast are going to have a booth there, and we will be recording probably 2 to 3 episodes from there. Usually they're include interviews with attendees and with our staff and just some good takeaways from the conference. We always have a lot of fun doing that. And I'm going to be doing 2 presentations while I'm there, one on strategic planning and another one on materials management. And the virtual conference for the ASC Administrators Bootcamp is going to be May 26th through the 29th. And for more information, just like with the DON Bootcamp, visit asc-central.com. And again, we'll provide a link to the show in the show notes to be able to sign up.
The Gulf States ASC Conference, which includes Alabama, Louisiana, and Mississippi, is June 17th through the 19th at the Ritz-Carlton in New Orleans.
The Arizona ASC Association's conference is June 24th through the 26th at the Sheridan Grand at Wild Horse Pass in Phoenix, Arizona.
The Florida Society of Ambulatory Surgical Centers annual conference and trade show is July 22nd through the 24th at the Hyatt Regency Grand Cypress in Orlando, Florida.
And CASA's annual conference, that's the California Association's annual conference and exhibits, is going to be September 2nd through the 4th, 2026 in beautiful Monterey, California. We will be there for that conference also.
The Pennsylvania Ambulatory Surgery Association's annual meeting and educational conference is October 4th and 5th, 2026 at the Eden Resort in Lancaster, Pennsylvania.
The Atlantic States ASC Conference, which includes North Carolina, South Carolina, and Virginia, is October 8th through the 9th, 2026 at the Embassy Suites, Raleigh-Durham Research Triangle in Cary, North Carolina.
The Ohio Association of Ambulatory Surgery Centers Annual Education Conference is November 11th through the 12th at the Ohioan Hotel and Events Center in Lewis Center, Ohio. Washington Ambulatory Surgery Centers Annual Education Conference and Trade Show is November 11th through the 13th at the Tulalip Resort and Spa in Tulalip, Washington.
And I'm still working with them. I am going to be there. I just don't know what I'll be speaking about yet. The New York State Association of Ambulatory Surgery Centers conference is going to be November 17th through the 18th, 2026, and a pre-conference on November 16th, and it's going to be at the Desmond in Albany, New York. And Sue, I think I'm going to be at all three of those November conferences, and they somewhat overlap. I don't know how that's going to work. So
a lot of flying.
We'll give you more details as that comes out. On-demand versions of our ASC Director of Nursing, ASC Administrator, and our Business Office Managers Bootcamps are available on our sister website at asc-central.com. No, we do encourage you to sign up for the live versions of it, and we know that doesn't work for everybody. And a reminder for everyone to become a patron member of the podcast. Don't miss out on all the benefits of joining our patron member program, which is available at asc-central.com. This is a comprehensive membership platform, and it's available both on your computer and on your cell phone. And it's a great resource for all aspects of ASC regulatory and accreditation compliance, operations, and financial management. And it really is designed with the busy schedules of administrators, nurse managers, business office managers, all ASC leaders in mind. When you become a member, you gain access to our regular Zoom sessions, typically held weekly, and recently they've been on Saturdays, where you can engage with other patrons in our podcast team. As we mentioned earlier, often quite a number of surveyors are on also. Your membership unlocks a wide range of resources, including access to some virtual conferences, such as our credentialing conference and our conditions for coverage conference. And you'll also find valuable tools like sample policies, procedures forms, and our highly regarded fire and disaster drill kits. Your support helps us to maintain and grow the podcast, covering essential costs like research, travel, equipment, and production. And to learn more and become a member, visit asc-central.com.
Thank you for tuning in to this episode of the ASC Podcast with John Goehle. We hope you found the discussion insightful. If you did, please share it with your colleagues in the ASC community and be sure to subscribe so you never miss an episode. We appreciate your feedback and suggestions for future topics. Please reach out anytime at comments@ascpodcast.com.
And a special thank you goes out to our incredible team here, very dedicated team. Our sound editor, Susan Cronkite, executive producer, John Goehle, and our committed research team, Sue Cronkite, Jenna Alvarez, Judy D'Ambrosio, Mike D'Ambrosio, Zach Calritis, Jim Masters, Stuart Rosenberg, Amy Cronkite, Lori Rodricks, Kathy Foti, Donna Macchio, Christina Norman, and Katie Pearson. Your hard work makes this podcast possible.
Our theme music is by Media Sushi and Mike Noah. The ASC Podcast with John Goehle is hosted on Podbean and can be found on all major podcast platforms. Thanks for listening, and we'll see you in the next episode. This episode of the ASC Podcast with John Goehle is sponsored by Surgical Information Systems, RFX Solutions, MedServ, and Ambulatory Healthcare Strategies. Surgical Information Systems provides cutting-edge information solutions for surgery providers. RFX Solutions is your all-in-one healthcare regulatory compliance software. MedServ, which offers the only digital narcotics cabinet specifically designed and priced for surgery centers, helping develop standardized processes and compliance, eliminate paper logs, and prevent drug diversion. And Ambulatory Healthcare Strategies is the nation's leading regulatory and accreditation compliance resource for ambulatory surgery centers. For more information about our sponsors, visit our website at ascpodcast.com. This podcast is an educational and operational tool and is not intended to be a comprehensive resource for all rules, regulations, and standards that an ambulatory surgery center must meet. The advice provided should not be considered as, nor does it constitute legal advice or opinion. When reviewing specific situations involving legal and regulatory issues, attorneys and other professionals should be consulted. This has been a production of Eden Group Development. All rights are reserved. If you're interested in advertising or sponsoring the ASC Podcast with John Goehle, please email us at info@ascpodcast.com. We would love to hear your questions and comments. Please email us at comments@ascpodcast.com.